presenter. And thank you all for being here with us. And thanks for the committee for invitation. And of course, Dr. Amanda.
And just while they prepare his slides, we'll be having a panel discussion shortly after his talk. And I will introduce our esteemed guests for the panel.
Okay, so I will quickly take you through some of the development steps and some of the risks we see with an AI in the medical field. We had seen today from different speakers how AI is really engaged and really useful to our field. And we all have to use AI. If not now, it's going to be later on. AI is not going to replace us because, as you saw from Dr. Alexander, there is a huge burnout. I'm working on 150 plus countries across the world. None of them are not complaining about radiologists and physicians burnout. It's a huge problem. And even regulatory bodies across the world are looking into how can they facilitate not only the radiologists, but also for other physicians to have an enhanced workflow, to have an easier work in the hospitals, so they can produce more with the number of physicians and radiologists we have in the field. Just to quickly, when we think about AI, we should all think about different generations of AI, including machine learning, deep learning, and most recently generative AI like ChatGPT. But also we should think always about the AI in every step of the patient journey within the hospital. So AI is not only on the imaging or post-processing or to enhance the image quality. There are so many tools in AI for intelligent protocoling, for example, which can help you select the best protocol for this patient based on the history and EMR data of the patient. There are even more predictive tools in scheduling of the patient. So you can see, you can expect the no-show, so you save your slots on your scanner, especially if it's an MRI scanner. So how we do usually training, or how we train our algorithm, or develop the algorithm. So there are few components, and one we are extremely engaged as a radiologist, which is data curation. Data curation is like how we structure the data, how we identify the use case, and then what's the data we need to collect to make that use case happen. And then we annotate those data, we anonymize or de-identify those data, and this is a huge part of the AI development, and lots of bias happening in the data. So this is something some others have started talking about, but this is a very important piece on how the algorithm have been trained, because the data is a big reason for how the outcome is going to happen with that algorithm. Then, as you see, we are still engaged in the evaluation or validation, but we also can be biased somehow, as we will see. This is just a couple of examples of how AI can be very nice. This is a chest X-ray, maybe with a little bit of low dose, so it's not the best image quality. And for me, I'm not a thoracic radiologist, so I couldn't pick up any lesion here, but actually AI was able to pick a lesion, to pick up a pulmonary nodules overlying the vessels with an accuracy of 45% or a probability of 45%. This patient went to a CT and was confirmed that there is a pulmonary nodules. So there may be some very good things where AI can help us. This is another one which is the super intelligence. We never will be, as a human being, will never be in that stage. This is a prediction. This is another tool which can predict cancer breast after a few years based on differences on breast fibroglandular distribution or asymmetry of both breasts and some other features. They can predict those women, or this woman can develop a cancer or have a high or mid risk to develop a cancer in 2 years or 5 years, so don't skip the mammography scans. We will never be, as a human, capable of doing such a things, the predictions. So AI is really helpful, not only in helping us in detection of the lesion, diagnosis, but also in the prediction. The other, or the new model now, which is everyone is trying to identify how we can use it in healthcare in general, is the generative AI. And generative AI is a little bit different on how we train the algorithm rather than the previous one. The regular one, where we get images, we train on each image, do the segmentation, identify the lesion, and then train the algorithm on those specific lesions. In AI, in generative AI, we add one more component, which is how we learn as a radiologist. So we add the component of the education or the text box. We add the component of this is a glioblastoma multiform. This is how it should enhance. This is how it presents in T1 and T2 in diffusion. And based on those data and the large amount of images and data, the AI can learn better than the previous way of learning. So we still provide some images, but we have more context in either large language models or foundational models, which is a base of generative AI, to develop more accurate and more specific and faster solutions. And just one example of just how this can be used today. Definitely I'm not advising this because this is not a regulated way of using, but this is how we see in different practices just through the ChatGPT. What you see on the right side here is an outcome of pulmonary nodule detection AI tool, which can detect many lesions in pulmonary nodules in lung CT, low-dose lung CT. But you need to take that and write that into paragraphs into your report. You will not just deliver that report, automated report from the AI. So what takes time is actually to write each paragraph for each nodule, for the location, the size, and your probability for malignancy. But if you took that report or that digital report, just put it into the ChatGPT, it actually can create to you what you want. And imagine some other stuff. I don't know if you had tried to talk to the ChatGPT and ask the ChatGPT to write to you a CT post-contrast triphasic exam for a liver with a patient with hepatocellular carcinoma. And you will see a very good details about how they specify the hepatocellular carcinoma from the wash-in, wash-out criteria, from the lesion characteristics and so on. So generative AI is coming, and this is now works on language, so it's more in text, but some companies are also working on developing it for imaging, including NVIDIA, including others as well, for either post-processing or for data annotation or AI reporting. And let's see some cases as well, which is created. This is a case on chest X-ray, and I believe there's very easy finding here, left side pleural effusion. Another case, bilateral lobastis, pneumonia. Those are all AI. Another case, emphysema. Anyone familiar with this case? What's the spot diagnosis? Metastasis, okay. So all of those cases are fake. So none of those cases are realistic. So what you see here on the left is the real case. What you see in the right, this was all fake AI generated images. And even in the chest X-ray, those are synthetic AI generated images. Those are not patients, they are not realistic images. And that's why we need to be careful as well. So as long as the AI does have the opportunity for us, but we need to know our AI tool very well. We need to be very careful in the selection of the tool, implementation and usage of this tool. And also one more risk which is new to us is the cybersecurity. Because now with malware breaches, they can have malwares which changes the configuration of the image, changes the pathology even in the images. As you were seeing by computer, we were able to blend the image and create the images we want, or implement a pathology which was not there into those images. And for that, as Dr. Michel mentioned before, there are so many types of bias in AI particularly. Lots of them are related to data. That's why we should be very careful, understanding very well how that training was being trained on, what kind of data they collected, what is the mix of those data. Demographics, although we may believe that demographics will add some more accuracy to this data, but if they are not used correctly, they can actually increase the bias on the algorithm work. So they may favor a specific ethnicity, they may favor a specific gender, and based on that, they add more false positives or false negatives. And for model development, we are familiar with many activities where they use an algorithm which is already available in the market as an open source, and then they build on top of it new algorithm. And this continue to happen, so there could be an inherent bias where even the base algorithm does have some bias, and you build on that bias. So lots of areas which bias can be included into the AI, but the one which I wanted to talk more about is the model implementation, which is more related to us as radiologists. So we need to understand that, as we mentioned, what the model was trained on, and I used my model in the same direction. So if my model was trained on high dose CT, not a low dose CT, so I'm not supposed to use it on a low dose CT. If my model was trained mainly on the data coming from North America, I cannot use that model to diagnose my patient in Africa or the Middle East or in Asia. So I need to have a good understanding about the model. I need to have a good understanding about how I should implement that model, not only from technical perspective, but also you need to treat that model as your colleague in the hospital, which is the new colleague, the new radiologist you have, the junior one or the mid-level one. So you need to build that trust with that model. You need to understand with that model where it really works well, where it really doesn't work well. And when you trust this, you will be able to drive the model to more sensitivity or more specificity. You will understand if this model works well in detection of the lesions, or this model works more into characterization of the lesions. It's the same as your colleague who you trust to refer or ask for a second look. You need to build that trust, and you need to build that trust as well with your AI. And it takes time. That's why we always advise you need to start soon, because it does have a learning curve on how you build your trust with the AI model. And those are a couple of great publications around different types of bias in AI model and the build on the AI models, and in each category, like in development, in data collection, in evaluation, which is a publication, as well as the implementation. And one last example of this is a real case. Don't worry, so it's not a fake case anymore. But this is, again, back to the opportunities where AI is really helpful. This is a case which just have done coronary artery bypass graft and open heart surgery. And after just the surgery, the X-ray was taken, everything looks fine. In a few hours follow-up, the patient start with no symptoms, just a follow-up. So the ICU, there was no radiologist in the hospital. This was done in New Delhi. No radiologist in the hospital at night shift. The ICU physician saw the X-ray and said, oh, it's a nice X-ray, I don't have any problems. But actually the AI highlighted a small pneumothorax. So this patient was on close observation because suspected pneumothorax, which had been detected by the AI and not by the physician on duty who was an ICU physician. Few hours more, patients started to have more signs of distress, and now it's an obvious, this is a big pneumothorax. Why I'm really interested in that case, because I have the same exact condition happen in Africa in one of the countries, and the patient died, because the ICU physician believed there is no pneumothorax and a small pneumothorax, and the patient left without good observation at night, and the patient was distressed, and the patient died. So you can have that, think about AI is not only for us as radiologists, because now our bandwidth is limited, and others, orthopedics are looking into images. Neurologists, neurosurgeons are looking at images. ICU physicians, emergency departments, all of those different practitioners or different healthcare providers or physicians are looking into images as well. And some of them are not trained enough, and they are obliged to do some of the decisions based on that due to unavailability of expert radiologists around. So AI can have a potential to save lives in different areas as well. So there is a risk, there is a potential. We need to understand both of them so we can adopt AI as early as possible. Thank you so much.
Thank you for an excellent talk. I'd like to now